Good morning, everybody, and welcome to Carolina Center for Medical Excellence Quality Leader Session. We are very happy to host today's session on advanced care planning and the POST tool here in South Carolina. I do want to give some reminders. We have a very exciting program coming about on August 3rd. That is an off time for us. We don't typically have a meeting on the first Thursday of the month, but this case, it is a free CE event. So we do welcome you to join us as we have Evelyn Cook come in to present to us on the elements of infection prevention programming. It's a good time of year to be doing this as we're looking ahead into the fall season, the increase of influenza and COVID cases coming down. So it's opportunity for us to really look at what our program entails. We only ask in return for joining us in this free CE session, you complete a very short 5-question survey for us. We are trying to collect some data on what the current numerator and denominators are the numerators and denominators of current staff that you've done training for an infection prevention practices. It's compliant with F945. CMS is asking us to collect that. So we just ask if you could take a few moments to give us just a few responses. We'll be able to move that forward in our programming and get that information off the CMS. So for today's meeting, we are privileged to have Wilma Rice with us. Wilma Rice is with the South Carolina Coalition for the Seriously Ill, and she's the chair of education committee there, the senior educator there, and also is owner of the Professional Medical Trainers program. So we're very pleased to have this wonderful presentation coming about to help us understand how the POST tool in South Carolina helps and correlates with the advanced care planning regulations that we're looking at. With that, I'd like to turn this over to Wilma.
All right, thank you, Alyssa. Welcome to everybody, and I thank you for being here, and I thank you for having me. I'm going to start with telling you that where I got interested in this from, and it was 28 years in the emergency department. And I saw so many families just torn apart when it came to what was happening in a patient care room. We were trying to figure out how much care they wanted mom to have or grandma to have. And the family was in the conference room arguing about it. And when they have arguments like that at the end of a loved one's life, those are feelings and hurt that stays with the family forever. They never go away. And I'm sure in nursing homes, y'all have seen a lot of that type of thing. So it has turned into a retirement passion for me. So what we're going to do today is first talk a little bit about advanced care planning, do a few comparisons, and then go into the physician orders for scope of treatment and look at the form, because this is going to be a real push for us. And I think it's something that really is important to the nursing homes. I'm a laid back person. If you have a question, feel free to let Alyssa know, put it in the chat room. And we've already talked about it. She'll bring it up to me and I will try to answer your question. And if I can't, I'll find the answer. So let's get started. First, what is advanced care planning? And this is a broad term. It covers a lot of things. For younger people, it's the what ifs, or for healthy people, it's what would happen if you could, or I could, let me put it on me, I could leave my house today and be in a car accident. It's not just for the elderly. We want advanced care planning done by an 18-year-old, okay? And that 18-year-old is considered an adult in South Carolina. It's not just for those who have a serious diagnosis. Yes, we really want that if they have been diagnosed with COPD, congestive heart failure, cancer, anything like that. But we want those healthy young people to have an advanced care planning document in place for that sudden illness or injury that might happen. When I talk to young folks, I tell them, please do not make your parents make a decision about what treatments you get if you can't speak for yourself without knowing what you want. I couldn't imagine having to do that. Another definition is it's a process. It supports adults at any age, any stage of health that you might be at. helps you to share your personal goals, your values, what type of care you think you want in the future. Advanced care planning in general is about future care. And what I've got on the slide here is a conversation going on with someone who's just been told they have congestive heart failure. And it's all about that conversation. And this healthcare provider is trying to figure out, what does that mean to them? What have they understood about that diagnosis? This happens very often. We want people to do advanced care planning immediately after they're told they have cancer. And this is somebody who is not hearing anything, they haven't heard anything that's been said after they've been told they have cancer. So they can't make decisions right then. For us, it's doing what you can to make sure that your wishes are known, right? And make sure that the treatments that you're going to get are consistent with those wishes. And the little diagram I have there, basically you want the right people to have access to your wishes, starting at the top of this. That means whoever you name as your healthcare provider, your healthcare power of attorney, your physician, nurse practitioner, PA, whoever gives you your regular care. If you have a regular hospital, let them have a copy. Right now, we're working on trying to get an e-registry going. We actually have one from a grant, but that will be running out at the end of the year. But how can we store these? And we'll talk about that a little bit at the end. You want to have access to the right services when you need them, based on what kind of services you want. It always comes back to what the patient wants. You want to be cared for, and you want to die where you want to be. I think the last thing I saw was 80% of the people say they want to, or 80% want to die at home, but that 80% dies in the hospital. Okay. And for y'all, the nursing home is considered somebody's home. You know, when I was in the ED, when we sent them back to the nursing home, it was considered that they were going home as far as transport. You want to be as involved as I want in decisions about your care when it comes to this planning. My 93-year-old father was on hospice. He died in September, but prior to that, he was on hospice, and we told him that he was going to drive the bus. And so when we had to have a discussion about what he wanted, and I remember one was how much pain medicine he wanted, he was able to make that decision, and he made it, and because he was driving the bus. So it's not, a lot of people think if they name a healthcare power of attorney, they lose control over what happens to them. As long as somebody can speak for themselves, they're in control. We want in advanced care planning people to have support for emotional, physical, social, spiritual needs, all aspects of the care, not just go in and have treatments. Somebody that's living the end of their life, they have emotional and social needs. And so many times they become socially isolated. And there's a lot of studies going on now about social isolation. The spiritual needs, do they practice Islam? Are they a Native American that needs a shaman? I was asked once by some of our chaplains, would we pass smoke over someone who had died in the ED? And I was like, you're going to have to explain that one to me because I don't know what that is. And myself, I had to go up to Catawba Reservation and talk to one of the leaders up there and learn all about passing smoke. And I knew that our fire safety person would just be all over me, but I would have to do it if that was going to help them. And that's their wishes. So advanced care planning is a lot. And the last thing I'm going to say is part of it's on you. It's not on health, all on healthcare. You have to take the steps to share what matters most to you. In our family, we have chats all the time, and it's a normal thing. And it's hard to get to that spot in your life, but you have to share what's important to you or nobody knows. So like I said, advanced care planning covers a whole lot of ground. So what I tried to do is bring it into an all-encompassing umbrella in one little place So think of this umbrella as the ACP, Advanced Care Planning. There's 3 stages. Healthy adults, what are your care goals for everyday health? And we're thinking of that unforeseen tragic accident or illness. We hear of 30-year-olds having strokes, the 28-year-old dying. We just had on Folly Beach a bride who was on the way from their reception to the home on Folly Beach on a low-speed vehicle, and a drunk driver hit him behind and killed the bride on her wedding day. That's not something that was planned for, obviously. So, what were the choices, and did she have something in place? But that's the kind of things we're thinking of here, to name that healthcare power of attorney and discuss it with your loved ones and your clinician. The next stage is you are getting a little older, and maybe they've been diagnosed with a chronic illness. And now you have your treatment goals are geared towards your changing health needs. Do I want to have oxygen? Do I want to, take these medicines or not? And maybe at this point, we need to do a review of your advanced directives, your healthcare power of attorney, because you've put your wishes on there too. And make some updates, because our values change over time. It's not a one and done thing. And what we're going to talk about mostly today is that adult with serious or life-limiting illness. Notice I'm not saying terminal illness, I'm saying life-limiting. So this is not treatment goals for possibly in the future. You have the illness, and now you need to know what you want done now. If you go to the hospital right now, what do you want done? And this is where the post comes in. And we're going to compare it, because I know you're used to the EMS DNR. We're going to compare those 2 forms shortly. One thing to remember about post, it is a transportable medical order that can cross all care transitions. All care transitions. All right. You can't talk about all of this. And I'm going to back up just one second. I go over this advanced care planning. It's geared more at the audience, because a lot of times when we are talking to healthcare clinicians, what we find out is roughly one third of healthcare clinicians have actually done advanced care planning for themselves. And the first question somebody you're talking to about advanced care planning is going to ask you is, have you done yours? And if you say no, you don't have a leg to stand on to have that conversation. So I would hope that when you hear this presentation today, that you go out and start doing your own advanced care planning. All right. And part of that is the conversation. Document is very important. The healthcare power of attorney is important. The post form is important. But neither of those documents are as important as having the conversation, because you lose the context of what is the document's trying to say. So advanced care planning has 2 very distinct things that has to happen. One is holding that conversation, and we have to have that conversation with our loved ones and with our physician or other healthcare clinicians. And we train social workers, nurses, APRNs, PAs, chaplains, and all to have these conversations at different levels, that everybody can help the patient have this conversation. And then after that conversation is had, then we work on completing the document. A lot of times having the conversation is the hard part, because by and large, a lot of healthcare clinicians have not been trained to do this, right? And I'm included. I think some of the hardest clinicians to have this conversation are oncologists, and because they feel like they've let their patient down if they have a conversation about this. All right, a little bit more about the conversation is, like I said, it comes before you complete the form. And this is something, when we were doing the post, one of our physicians' offices, the physician would start the conversation. Have you ever thought of this? And what are your thoughts about it? And if they were interested in carrying on that conversation, they would actually make an appointment with his nurse who had been trained with the conversation. And they would meet with the nurse, and she would have the bulk of identifying and exploring what their values and goals were, and then circle back to the doctor for the form. So working out workflows like that is very helpful when it comes to the conversation. And that leads us to who can have this conversation. It's not just on the doctors, y'all. As I said, we've trained chaplains in Anderson, South Carolina with ANMED. They had a program going, and I can't tell you if it is continuing right now, but the chaplain department, they would actually have appointments made for them to come to a doctor's office to have the conversation. And it was working really well. And I hope they've continued that from our grant and pilot program. There are things that can help the clinician have this conversation, because like I said, it's very uncomfortable to talk to somebody about how they want to live the end of their life. The serious illness conversation program is out of Ariadne Labs, and it's a 3.5-hour program. And it gives you a guide actually to follow to talk to the patient. And you can have it in front of you while you're talking to the patient. Just tell them, I've got this to help me not forget anything that might be important to you. And the other platform is Respecting Choices, and that's out of Wisconsin. And this is more for lay people. And but we use both platforms to help train people. So if you find that you're interested in any further learning about having the conversation, Alyssa can get you in touch with me. So in South Carolina, and actually across the country, the current state of advanced care planning is the lack of training for advanced care planning in nursing schools and med schools all across clinicians, any kind of healthcare schools. And they don't get the needed communication skills. And I've got nurses on here a lot because I've given this talk to nurses, and I apologize I didn't change it. But there's discomfort for clinicians in discussing end-of-life issues with patients and the families. And that comes from a lot of different reasons. Like I said, may feel like you failed your patient because they're going to die, right? Maybe it's a cultural thing. In South Carolina, a huge culture is the patient and the family don't want to talk about it, because if I talk about death, then somebody's going to die. And I have to tell you, I consider myself pretty educated, and people kind of poo-poo myths and stories and all this stuff. But I can tell you that I cannot wash clothes on New Year's Day. And I don't know if any of y'all have ever heard that, but there's an old myth that if you wash clothes on New Year's Day, somebody in your family is going to die. And my head knows that is untrue. But my heart will not let me wash clothes on New Year's Day. So those kind of cultural things come in that and make it even more uncomfortable. There is a huge lack of knowledge about the ACP documents, and we're seeing that really driven home. One of the doctors in our coalition is being treated for cancer right now, and he met with the palliative care group, and they actually had no idea about any of the advanced care documents, no idea. And people don't understand what the document is telling them, how they guide the decision-making process. And when you add the post law, which is relatively new, it was actually signed into law in May of 2019. And as we were starting to gear up all of the education, here comes the pandemic, and it kind of shut everything down. And that's why a lot of people don't know about the post law. But it adds another layer to what is already not understood and what already makes us uncomfortable. And since we say post is for someone who it wouldn't be a surprise if they were to die in the next 12 months, which is a lot of your patients, it makes folks even more uncomfortable, right? Because we're talking about people actually dying here. We have done some things to make it better. I worked with a $1.8 million grant, and we branded it My Life, My Choices. And there is a very good website, mylifemychoices.org. But we did nursing education changes where we actually have helped universities do programs. I know at my hospital, we had nurses do like a Maymester, 8 12-hour shifts that really immersed them. They worked 7 shifts on the oncology floor and 1 12-hour shift with the palliative care team. And that was really an eye-opener for them. But getting this kind of training into actual nursing schools, med schools, and we've done that at MUSC. We start with the first year med student, and they're given a 45-minute presentation on advanced care planning, and they have all kind of assignments, and ending up their first year with doing their own advanced care planning. And then the next year we do a symposium about the end of life. And we're looking to try to replicate that process. The My Life, My Choices initiative in South Carolina had 5 rural underserved areas where we brought together churches, hospitals, nursing homes, all type of facilities together along with the community. And we taught over 1,000 clinicians about the conversation. And we taught we educated over 11,000 people in those 5 areas, community members, on advanced care planning. And then the post legislation is trying to make it easier for wishes to be known. So a lot of things are going on in this realm. So I know I'm talking fast, but I want to make sure I get all of this in. And that brings us to the post form. And post form, physician orders for scope of treatment. Number 1, it is the oversight was given to DHEC in the law. And again, the pandemic kind of stopped them from doing education with EMS. So we're gearing up with that again. But a post form right now, you've got to have a serious illness. You've got to have that diagnosis. We're starting to get calls from geriatric people. I have had several calls come to me from somebody who's 82 years old and has no real diagnosis of anything. They're healthy, active, and they want to do a post because they want to record their wishes. And I have to tell them, you're not a candidate for a post. You need to do your healthcare power of attorney. And they're really disappointed. So I actually brought that problem up to National Pulse earlier this week when we had a meeting. What do we want to do with this? But the law, our South Carolina post law actually defines what that serious illness is. And I'm going to read it. It's defined as a condition which, based upon best medical judgment, is likely to result in death within a period of not to exceed 12 months. Now, sometimes this makes people a little nervous because the clinician who's signing the post is like, well, what if they don't die in 12 months? Then I'm going to get in trouble or something. No, you're not. It's okay if they live past 12 months. The form is still good. All right. We want to review it to see if those are still their choices, but the form is still good. The other part of this that we were very intentional about, we had the Alzheimer's group working with us on this, is knowing how badly dementia affects people. And I'm sure this is near and dear to your hearts in the nursing homes. Based upon best medical diagnosis, again, the best I can tell, this person may be expected to lose capacity within 12 months. And this is huge because say I was diagnosed with early onset Alzheimer's or some other type of dementia tomorrow, then according to what kind of problem I'm diagnosed with, we look forward and are we looking at possible loss of capacity in the next 12 months? If the answer is yes to that, I can do a post. So that's a little bit different from that serious illness because it is looking to the future a little bit more. But that's very important with our folks because if you lose capacity, you can no longer make your own decisions. They have it recorded right there on the post form. So those are the two conditions where a post form applies. All right, post versus advanced directives. This is a big thing because South Carolina has several forms. Advanced directives are for that future care. This is what I think I want in the future. And the advanced directives that South Carolina has right now is the healthcare power of attorney, which is the one that we are pushing. The living will, or desire for natural death is the name of the actual law. And 5 wishes. Okay. The two most used, I think, are the healthcare power of attorney and the living will. We're trying to get away from the living will because that only applies in a very narrow scope. Right? The living will, you have to have a permanent vegetative state or terminal illness. And there's a lot of things that go into this that people don't understand. And I'm not going to try to teach you about a living will. But one of the provisos that's in the law says that you have to be in that permanent vegetative state for 90 days. If I've been in that state for 89 days and I wake up and say hello and go back out, then we don't start at day 89. We start at day 1 and start all over again. And if I've recorded my wishes that I don't want this done and that done, that living will trump any other document, right? Even if you did that living will 30 years ago and you just did a post, right now, that living will trumps everything, right? And that's not a good place to be in. And we're working to iron that out. An advanced directive is anyone that is 18 years or older. And remember, we want those folks to do that. It outlines wishes for your future care. And this is usually a legal document. And the healthcare power of attorney and the living will. The healthcare power of attorney has on it optional notary. The living will it requires a notary, but for healthcare power of attorney is optional. So usually these come out of a law office with a lawyer. No medical person is involved with them, whatever. The big thing about an advanced directive, it is not actionable by EMS, right? So if somebody, and there was an actual story with respecting choices about a gentleman who had aortic stenosis and he did not want any care done and he had a post, but he was still trying to go out there and play golf and all. If he had dropped dead on the back 9 of the golf course with a healthcare power of attorney or living will in his back pocket, EMS would have had to do CPR on him, right? If he had a post, which we said is a medical order, they could have honored the post, but not the advanced directive, right? So let's look at the posts in comparison. Again, transportable end-of-life medical order. This is how the person wants to live the end of their life. It's based on their life-limiting medical condition or frailty, that possible loss of capacity is not based on their age. We know that younger and younger people are being diagnosed with problems. There are pediatric patients with frailty and their life-limiting condition. It's going to tell the end-of-life goals of treatment, and you'll see that when we go over the form. It crosses all the care transitions, and the big one here is it is actionable by EMS. And then it's based on this conversation that's held between the clinician and their patient, or the clinician and the patient and their family. And when I say family, we also want to include the person that they've named as their healthcare power of attorney, because we still want them to have done the healthcare power of attorney. And the post just complements that. but post is not an advance directive. It is a medical order for treatment now. This is what I want. So I'm going to stop there for a second. Any questions with this comparison? Just stick it in the chat room and I'll just keep going.
Wilma,
Yes.
this is Chris. So did I understand you to say that if someone has a historical living will, that currently it would trump a post?
I think there would be some argument for it. But most of the time what we're trying to do is look at the latest dated thing. And that being a medical order, I think the post would be followed more than the living will. But if you've got a healthcare power of attorney saying this is what they wanted, we just talked and they wanted them that, and I may have misspoke that, and I apologize. What I can tell you for sure is the living will trump whatever the healthcare power of attorney says. If they, like I said, have just talked to this person and knew that they had changed their wishes, they could still invoke, medical care could still invoke that living will, or legally it could still be invoked.
Okay.
But we are trying to get people across the country to look at what is the latest dated thing, because that would be more appropriate for the person, because that's what they have said at the latest time. But people get things done. They get documents done and they forget about them, especially if you did it when you're young. And I've had people tell me that lawyers have told them to put this kind of documentation in the freezer, because if the house catches fire, that'll be the last thing to burn. So they're not really available to us. So it can be tough. Does that kind of help you?
Yes, thank you.
Okay. All right. Okay. All right. Another comparison, which I think is important, is the EMS DNR order that we already have. And a lot of people are asking, why are we doing post if we've already got the DNR order? And I'm hoping to show you why. First off, they're both medical orders. Both of them are signed by the clinician. All right, the big thing here is that EMS DNR order's only choice is do not resuscitate. All right, that's the only choice they get on that DNR order. On the post, they can choose whether to resuscitate or do not resuscitate. That's section A. Yes, I want it. No, I don't want it, because we want the person to be able to choose yes or no. All right. There's a lot of other decisions that can be made. The EMS DNR is for patients with a terminal illness. And like I said earlier, the post is for those that have a serious illness. They're expected to lose capacity within 12 months or either one of those. Okay. And I will tell you, across the country, they're starting to go to 24 months in the literature, but our legislators were more comfortable sticking with the 12 months. So that's what our law says, but you may see in the literature 24 months. EMS DNR, it only applies to resuscitation. Do I do CPR? Yes or no? For post, it allows for other medical treatment. It allows for that patient to truthfully tell that the medical team what they want done. EMS DNR is only for EMS while they're in the back of that truck. For the post, it's honored across all healthcare settings. So that's why we call it the transportable medical order. A lot of times when people are taken by EMS to another facility and they see an EMS DNR, it's like, okay, well, we'll just use that. It has no application in a nursing home or in a hospital. It's only for the EMS people. They have that post, you can honor it in the nursing home and the hospital. If somebody has to leave to go to dialysis, it goes with them because it can be honored at the dialysis clinic. So Those are the big differences between the two. So again, questions.
Wilma, we've got a great question from Deneen. She is asking if the post is followed during surgery, like the day expected in her experience of working in that environment.
Okay, during surgery, that is a great question because it comes up all the time about even for hospital DNRs. And what I have learned is it's one of those myths that a DNR or a post is automatically stopped for surgery. There should be an order that rescinds that DNR and then it's restarted. It is not an automatic thing. It is not an automatic thing. So if somebody goes in the hospital and they have a post or maybe they have a hospital DNR, they need to question it if they're going to surgery. Or, although if they have a DNR, I'm not sure why they'd be going to surgery. But that's something you need to look at facility by facility. So if you've got a regular hospital you go to, you need to check with them. But I have learned in the literature that it is not automatic. And even OR people will say, we cancel them. Well, that means by order, it's canceled for the time because they think they probably caused the problem. So we should be able to resuscitate them in the OR. But it's not an automatic thing. Thank you for that. All right. So I'm going to spend the last half of the presentation looking at the post decisions, what the sections are. Now, the top of the form, I'm not showing on this presentation, but it's the demographic thing. And those demographics are important when we start keeping these because especially when we're doing it by humans, you want to make sure you're doing a post on the right person. Okay, we've got a lot of Mary Smiths, John Browns, so we ask that you please do put the middle initial in because that may be the deciding factor. The last four of a social, I know people are nervous about using the social security, but we're just asking for the last four. We want the patient's address, not the representative, if it's a representative doing this. And I will tell you that a patient's healthcare power of attorney can initiate a post for someone who does not have capacity. All right. So those demographics are very important. So section A, you only get to check one box. Now remember, do not look at this as check, 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 check. All right. Remember, we've had the conversation. So attempt resuscitation. And if you say, I want to be resuscitated, then it requires in the next section that you pick full treatment. All right. And that's important because you can't say in one section that I want you to resuscitate me, and in the next section, hamstring EMS or you in the nursing home. You can't say resuscitate me, but don't intubate me. All right, so it's full treatment if you want to be resuscitated. Do not attempt resuscitation, DNR, allow natural death, whatever the terminology is. And I want you to look where it says across the top of that section, cardiopulmonary resuscitation, if the patient is found unresponsive, pulseless, and not breathing. And that's going to be really important in just a minute. So do you want to be resuscitated or not if they find you unresponsive with no pulse and you're not breathing? Okay. If you're found and you're not in cardiopulmonary arrest, we're going to go to sections B, C, and D. All right. So section B, and I think this is the most important section for EMS, but it's going to help guide y'all a lot too, because in many ways, y'all are a lot like EMS when you find your patient down and all. So at the top of this one where it says medical interventions, it's really important that you see that if the patient has a pulse and or is breathing. So I've got the same disease I had in section A, but now you find me and I'm still alive. All right. The post, if you find somebody dead and they've picked DNR, it's not hard to figure out what to do. Leave them dead. All right. But the real stress comes if they are a DNR and they're in distress. How far do I go? All right. So the choices here, full treatment. This is basically, we're going to throw everything at you that we can, including intubation. We're going to cardiovert you. We're going to defibrillate you. Whatever we can do. And you may be put on a ventilator. So this person who has picked full treatment, they're going to be transported to the hospital and probably go into intensive care. All right. This is a guide, not, where they go is not going to be the gospel, but this is what we're trying to help people understand about these different levels of treatment. Limited treatment is, yeah, I want you to resuscitate me, or if I'm still alive, I want you to do what you can for me, except do not intubate me. All right. I don't want advanced airways. Nothing goes down the throat, but we can use less invasive ways to do it. CPAP, BiPAP, put oxygen on them. If somebody has chosen limited treatment, then they're probably going to go to the hospital if it's indicated, but we don't want to put them in ICU if possible. What usually happens is they end up in ICU anyway because they're in distress. But it would be great if we could avoid ICU because we're not going to intubate them. Comfort measures only. This is all I want. This is somebody that usually is going to stay at home or in the nursing home, which is their home. They don't want to be transferred for life-sustaining treatments. The caveat here, it doesn't mean absolutely do not transfer this person. It means as long as you can meet their needs for comfort care, they stay where they are. If for some reason you can no longer meet their needs where they are, then you transfer them to the hospital. So if you had a patient in your nursing home that was having severe pain, and you are given the drugs by order and you cannot get it controlled for them, that would be a reason to transport them. Otherwise, we want to try to keep somebody on comfort measures at home. Okay. This is a very scary thing. People are scared to identify comfort measures by and large, because at least in the hospital, they're scared that if I put comfort measures only, they're going to stick me in the corner and forget about me. And nothing could be further from the truth. We're going to keep them warm and dry. We're going to offer them something to drink and eat as long as they can do it. We're going to relieve their pain, and we're going to take care of their wounds and try to prevent wounds. All right. So I want to give you a good example. When we were doing the post-pilot up in the upstate, they were having a lot of people being resuscitated. They chose that in Section A, and then they would choose full treatment in Section B. And that was really confusing people. How can they, they were choosing do not resuscitate in Section A and full treatment in Section B. And it's like, folks, you got to talk to me on this one because I don't understand it. But think about somebody with COPD. Their life is, I've got COPD, they have an exacerbation, they go to the hospital, they get intubated, they get better, they go home. Repeat, repeat. We know one day they're going to get intubated and we're not going to be able to wean them off of that ventilator. So when it comes to making, their trajectory has gone downward as far, and they're going to probably die in the next 12 months. The question we want to ask is, when would it be inconceivable to you to be intubated? When would you want intubation to stop? What are your parameters? But if you think about it, and this is why I said if they have a pulse and a breathing is important. Somebody with COPD is used to that being intubated over and over again and getting better. So of course, if they're found breathing, they want to be intubated. That's normal to them. So that's why I need to ask them when would it be unacceptable to you to be breathing? And usually they're going to come back, well, if they don't think that I can get taken off of it. All right. So they may have been full treatment for a while, but now they want to go to limited treatment. That's why the review is so important. So There is a place at the bottom of this section for additional orders. So if it's not listed here, maybe they want to refuse dialysis. This is a good place that someone could write no blood products. Anything that would be against your wishes that might happen with your disease process, okay, can be written there under additional orders. So very important. Yes.
We have a question on this that may align with what you just said.
Okay.
Just asking if there's an option which allows full treatment for a period of no longer than a set amount of days, and if that's where you write it down in that area.
Yeah, but you want to put parameters in there, and I'll give you an example in the next section. Because like I'm a control freak. In my healthcare power of attorney, I've actually written out underneath where I said you can do CPR, but I've actually written, if after 7 days, I don't know who I am, where I am, or who I'm with, I want all curative treatment stop and comfort measures started, up to and including pain medicine, even if it stops me breathing. Okay, because I know how scared they are to give pain medicine. So yes, it can be like that. But you want to give good parameters, not just days isn't a good thing, because time doesn't really have that much. But that's why I put, if after 7 days, I don't know who I am, where I am, or who I'm with, because that tells me my brain's not working. Great question. So section C and D, the legislature wanted the antibiotics added in because sometimes they try to give vancomycin to a dying person and it's not going to do them any good. If I'm dying of lung cancer, vancomycin is not going to prolong my life. So the choices here, only one choice, is use antibiotics if it can be prolonged. If it will prolong my life, you can give me antibiotics. I don't want to make a decision, which is the second one, basically. We'll make the decision when the infection occurs. And then the last one is no antibiotics except for relief of pain and discomfort. This would, think about it, if somebody is in the dying process and they get a UTI, that can be very painful. So an antibiotic to get rid of the UTI would help be comfort measures to relieve their pain. Those bladder spasms are bad. And additional orders. So you can put, just like before, the parameters. You want to give the parameters for any time limiting type thing. All right. You could put, if I get something, I can check no antibiotics except for relief of pain, just to be sure they understood. Please give pain or antibiotics to relieve minor infections causing pain, something like that. Section D is artificially administered nutrition and fluids. And this is where we say we always offer fluid and fluids if it's feasible. That's if the patient wants it and can tolerate it. I'm going to look at the right side of this one first, the IV fluids. Either they want long-term IV fluids, a trial period. And if we do a trial period, again, under additional orders, we want those parameters. If leg swelling, discontinue IVs, because I can tell you folks, if you're on long-term IVs and you start having the swelling from the IV fluids, it's very painful. It's very painful. And they may want that to be their parameters to stop IV fluids. No IV fluids, don't put a line in me at all, or I'm going to wait and decide if it comes up. Pretty straightforward. Where we get into the emotional part, and what I have observed is people can decide whether to resuscitate or not resuscitate. It's when it comes to artificial nutrition that the emotion comes in, because face it, folks, in the South, we feed people. All right. I had a brother die 25 years ago, and he was 2.5 hours away from me. And by the time I got there, the neighbors had already brought food over to my aunt's house. And I got there in 3 hours. All right. That's packing and getting there. We feed people. And it's part of our culture. So the choices here, long-term, you can put the NG tube down. That kind of says we'll get a PEG tube there. or a trial period of artificial nutrition by tube, parameters there. If not gaining weight within 14 days, stop it type thing. Do not insert one. I do not want a feeding tube, or decide if the situation arises. And I was actually having a conversation with the daughter and working to fill out a post, and her mother was going back to the nursing home, which is where she had come from. And like I said, when I got here, this is when the tears came. And when we're having the conversation, and this is very important, we're not trying to sway people one way or the other to have, of what to pick. The person who's facilitating the conversation, their job is to give information. So when I teach facilitators, I always tell them you need to remind yourself of how the body shuts down. Because when she started having tears, I said, you feel like you're starving your mother if you say no. And she said, yes, that's exactly how I feel. I said, this is your decision based on what your mother would want. And we talked about her mother a little bit. And I said, what I can do is give you the information of how the body shuts down. And the gut is one of the first to go. And with that discussion, she was able to peacefully say, my mother would not want that. Okay. And chose not to insert a feeding tube. So that's a very important section there. And again, expect the tears there. Sections E and F, bringing up the rear here is, and this is a little bit old, an older one. I hope you can see the red. It's the signature. Section E is the physician, advanced practice nurse, or physician assistants. All of these clinicians can initiate a post. It doesn't have to be a physician alone, but they have to sign, and that's where I've put the red box around, and date, because that's when it takes effect. We want them to print because we know most of these people, you can't read their writing anyway. We want a phone number, and we want their license number, and want them to check what is their discipline. All right. And under that, right above section F, in really tiny font, is we want them to let us know who participated in the discussion. And was it a patient with decision-making capacity, or was it their legal representative, or was it somebody else? All right. Section F, the patient signs, or their legal representative. And again, I know I said it earlier, that legal representative, if the patient does not have capacity, they can initiate a post based on what their loved one would have wanted. So basically they're signing that they know that this form is voluntary. And I cannot emphasize this enough. This is an issue sometimes. You cannot make having a post part mandatory for you to be admitted to your facility. It is a voluntary document. If you demand a post or require a post for admission, you're breaking the law, because it is clearly stated in the law in boldface that it is voluntary. All right. You want to have the conversation and then see which document is best for this person. The patient or their representative signs it, and they put the relationship. If it's healthcare power of attorney, that's what they write. You can put /daughter or whoever, if it's a relationship also, but they should put healthcare power of attorney. If the patient's signing it, we want them to write self there. All right. Print the name, the date, and if the dates match between the physician and the patient, then we're good to go. Whichever one is the later date that both of them have signed, that's when it becomes actionable. And here the phone number is going to be a little different. If it's the legal representative, we want their number, not the patient's number. All right. Section G is if you have a trained facilitator, and like I said, with the physician's office earlier, that they made an appointment with the nurse to kind of find out what their values and goals are. then they would print their name here and the date and their phone number, just in case somebody needed to clarify something with them. And that's somebody who's been trained with either respecting choices or serious illness conversation. Now, there is a backside to this form that I'm not showing here that gives you some information. We intentionally put all of the treatment choices on the front so that there was no flipping over. All right, let me stop there again. So this is the post. Any other questions about the form itself? I do need people to understand that this form is not yours. It's not the healthcare facilities form. It belongs to the patient. So if you have a patient who comes into your facility with a post, you need to go ahead and make a copy for their records. I know probably y'all keep it in the chart, but if they are discharged from y'all, it should go with them. The original should go with them. All right. This form is theirs to take to each transition of care that they go to. Okay. And I say go ahead and copy it because one of the things I got in feedback from EMS employees was that sometimes when they go to a nursing home, they say the patient has a DNR or a post, but it's not available because somebody has taken the whole packet somewhere else to copy it, to give to them, so they don't have it there right then. So I really encourage nursing homes to go ahead and make their copies of this form and have it right there so EMS can have immediate access to it. Reviewing post forms are important if they're transferring from one care setting to another. So say somebody comes to you from the hospital and they have a post form. Then what we would say is you ask them, are these still your choices? Or ask their representative, is this still the choices? And then you can put it on your order sheet. Right. Sometimes hospitals have said, well, the doctor who signs the post isn't on staff with us. And this is what we tell them to do. Just review it with them really quick and fill out your order sheet with the same orders. Okay. If there's a big change in the patient's health, maybe somebody came into you in assisted living or independent living, and then something happens and they're in the skilled nursing, then we need to review it and see has your choices changed. Maybe the patient, they've just said, you know, I'm feeling so well, I want to change this. I want to be resuscitated. And usually a really good place to look this over and review it is the patient care conferences when you have those, and let the whole team know about it. So again, it's not a one and done because things change. When you void a post form, it can be voided verbally. If somebody says, I don't want my post form anymore, what we want you to do is, it's hard to show on here, but diagonally draw a line across it and write voided and date and time it. Right? If they want to request a change on this form, they want to go from attempt resuscitation to DNR, you can't scratch out something, write error and initial it, and then check DNR. That means you void the current one and you have to do a totally new one anytime their decision changes, decision-making changes. And again, if there is a big change and they decide to do it. Storage is a big thing. Right now, like I said, we have an e-registry that is, it's wonderful. And it actually has an e-post form that you can fill out online. But if we can't get the state to take it over by the end of the year, it's going to go away. We'll still have all the forms that are in it, but we're looking for a home for it to live with the state, because the goal here is to have these things available when EMS needs them out in the home. So if we've got an e-storage, the dispatcher has access to it and says, you know, you're going to the address for this patient and they have a post on file and this is their wishes. So EMS walks in and knows. Again, the original copy stays with the patient. And if they're at home, we tell them to put it on the side of the refrigerator or over the head of their bed. So it's visible, not in the freezer. It still gets overlooked sometimes, but it needs to be very visible. Like I said, at nursing homes, y'all may keep the original copy while they're there, but if they leave, it needs to go with them. Scan it into electronic medical record. If it's, you keep a copy of it, even if the patient is transferred to a different setting. When they come back, you've got the copy of it. Is this still what you want? And then you go from there according to what the review shows. The e-registry, I've put a little bit about here. It's secure, it's web-based, it's wonderful. This conversation guide using the serious illness documentation actually supports CMS billing about ACP conversations. A lot of clinicians don't realize that this is a billable conversation. And they're losing a lot of income because of that. I'm not going to go into that a whole lot because it is facility based. If somebody is interested in it, give me, contact me and I will send you to the person who is overseeing that right now. How does this affect y'all as healthcare clinicians? Number one, anytime you change something, it's going to have an effect. Some people don't like change. That effect may be negative. Some people embrace it. Some people are careful about it. But if you train to do this, one of the big things, it increases your communication skills. It makes a difference of how you talk about things with your family, how you address certain issues and all. Another way is that by being involved with ACP and these end-of-life conversations with the patients and family, sometimes people think that's going to make it an uncomfortable situation. But most of the qualitative type feedback we've gotten from patients is they felt closer to their caregivers because they felt like somebody was really listening to them and listening to what matters most to them. And there was a better relationship with their caregiver. Think about how it would feel for you if you know what your patient wants, how they want to live the end of their life, and you're able to do that for them. That you're sad the patient dies, but there's a place in your heart that says, I did what my patient wanted. And that is better job satisfaction, which is important to healthcare workers right now because of burnout. We're losing people by the drugs. I feel kind of guilty, y'all. I retired in March. I've been doing it for 45 years and I felt guilty about retiring from my hospital job. I haven't retired from everything. And it also helps people get to complete their own personal advanced care planning documents, which I really hope y'all leave here and do, all right, or get started on the process. So there are some positive effects for healthcare clinicians in learning how to do this. So I always kind of end these talks with something by Hippocrates, those many years ago, because I think we've forgotten this along the way somewhere. Cure sometimes, if we can cure it, let's cure it. Treat often, but we always comfort, right? We've got this terminology in healthcare called feudal care. There is no such thing as feudal care in healthcare. There are medically unnecessary treatments, but no care that we give is feudal, all right? And so I think that's why this resonates. Cure sometimes, treat often, comfort always. So that's what I have. I'm sorry, I went 5 minutes over, but I'm I'm happy to answer any questions. If we have to stop, Alyssa, if you want to forward questions to me, whatever you want to do.
Oh, no, not a problem. We do have a few minutes left that we can talk about anything that comes
Okay.
up. I did want to confirm, Carrie had asked the question, if a resident goes to the hospital via EMS, we send the original document because we have a copy on hand.
Right, the original document should go with them. And the hospital should copy it and give the original back to the patient to come back to you.
Then you don't have to try to interpret if this is the most recent copy.
Right, right. And that's the beauty of the e-registry. You always know what the most recent copy, because you can do the post online, but you can also upload advanced directives. So, post is a complement to advanced directives. We want you to have that healthcare power of attorney, and then when it becomes necessary, a post. But always have that healthcare power of attorney and talk to them. Let them know that you've been named as a healthcare power of attorney. I can't tell you how many times I've seen people be told you're so-and-so's healthcare power of attorney, and they are clueless. And they've never talked to them about it. So need to have the healthcare power of attorney, and then when it becomes necessary, the post.
Perfect. Thank you.
Anything else? A lot of didactic, I know, but there's so much that goes with this.
Deneen is commenting, this was an excellent presentation. Thank you for it.
Thank you. Thank you.
I did link our emails for myself and Chris Williamson. So if anybody has any questions, the first email I listed in there did not have the in the line. So, that will make a big difference in reaching out to us successfully. Some of the emails we will be happy to connect you with the South Carolina Institute for Critically Ill and work with them on any comments that you have. I also thought this was a great opportunity to link in the survey pathways for nursing homes on hospice and dying. These are great tools that our surveyors are looking at. This is what the survey process is, and it references F552, which is about honoring residents' wishes. So it's a good opportunity as you're thinking about practices to look into what this guidance looks like and bringing it into your quality assurance process.
Yes, yes. And I would ask you if you know of a contact within the surveyors, because we've got a group that's trying to work on a few problems. I would love to have a contact in that group. And nationally, we are going to, our quality and research committee is going to be working on, that's where we're looking at the long-term care facilities, their surveyors. That's how we can influence education about post.
Let me see what I can find out, Wilma, and I'll be happy to
Okay.
share it with you. Very exciting. So
yes.
I'd love to keep the door open for you to come back in the future as you see changes or you see opportunities, and we would love to have you come back again.
Okay, love to. Thank y'all very much.
Thank you, everybody. Have a fantastic day.